Okay, let's unpack this. We are diving deep today into a topic that affects, well, many lives. A complex condition, obsessive-compulsive disorder, or OCD. Our mission with this deep dive is pretty specific. We're taking your comprehensive revision notes on OCD and turning them into a clear, high-yield breakdown right here, conversationally. Think of this as a shortcut to getting the core information solidified quickly and thoroughly, whether you're revising or just aiming for a really solid grasp of the subject. We're working entirely from that stack of material you shared, pulling out the key insights directly from your source.
And understanding OCD is crucial. As the notes highlight, it's a chronic condition that significantly impacts daily life. So processing this information in a structured way, like we're doing now, isn't just about listing facts. It's about understanding the clinical picture and, well, why these different pieces of information matter in the real world.
Absolutely. So let's jump right in. The most fundamental question. What exactly is OCD? How do the notes define it?
Okay, so the material defines obsessive-compulsive disorder as a chronic psychiatric disorder. Its defining features are recurrent, intrusive thoughts, those are the obsessions, and repetitive-driven behaviors or mental acts, which are the compulsions. The core issue here is that these obsessions and compulsions cause significant distress for the person and really get in the way of their daily functioning. So you have these unwanted thoughts, images or urges, the obsessions, and then you have the actions, observable things like checking or cleaning, or even covert mental acts like counting or praying that the person feels driven to perform. Those are the compulsions.
Okay, that gives us the core definition. The notes immediately jump to some additional details right after that, like mentioning genetics.
Yes. Right off the bat, the notes point out that OCD is often genetic, meaning there's a higher risk if first-degree relatives have it. They also link it to specific brain chemicals, neurotransmitters like serotonin, dopamine, and glutamate. There's even a note about pregnancy potentially acting as a trigger for onset, which is interesting. A key point the material stresses is that while compulsions are done to ease anxiety, any relief gained is usually only brief.
Only temporary relief, right?
Exactly. And critically, the notes highlight that delays in diagnosis can lead to significant disability. This really underscores why understanding and recognizing this condition early is so important.
That point about diagnosis delays leading to disability really does underscore the urgency here. So understanding what it is vital, but where does it actually come from? Let's look at what the notes say about etiology, the causes.
Well, the notes present the cause as complex, likely a mix of genetic, environmental, and neurobiological factors.
A bit of everything.
Yeah. We already touched on the genetic side with family history increasing risk. The material reiterates the importance of neurotransmitter imbalances, specifically mentioning serotonin again. It also notes that developmental and psychological factors play a role, and as we mentioned, stressors like pregnancy could potentially trigger its start. There's also a mention, though it's noted as rare, of a link to neurological conditions or even brain trauma.
Given that complex mix of potential origins, who does the material suggest is more likely to develop OCD? What risk factors are listed in the notes?
The notes list several clear risk factors. Having a family history, not just of OCD itself, but potentially other mental health disorders too.
Okay.
Certain life events or traumatic experiences are listed. Pre-existing anxiety or depressive disorders also increase risk. Interestingly, childhood onset is noted as a factor, and male gender is listed as a risk factor, even though the condition affects both genders.
Okay, diving a bit deeper into that, how in the brain, what do the notes say about the pathophysiology? What's going on under the hood?
The material points to dysregulation in specific brain circuits. It names the cortico-striato-thalamo-cortical circuit, often, abbreviated as CSTC.
Is it?
Yeah. And what's believed to be happening is that abnormalities in those neurotransmitters we mentioned earlier, serotonin, glutamate, they disrupt the signal balance within these CSTC circuits. This disruption is thought to lead directly to the repetitive thoughts and behaviors, the distress, and the functional impairment we see as symptoms of OCD.
That makes sense, sort of a breakdown in the brain's communication lines leading to these disruptive symptoms.
Pretty much, yeah.
So if someone is presenting with these kinds of symptoms, how do doctors use this info to be sure it's definitely OCD and not something else? Let's talk differential diagnosis.
That's a significant challenge the notes highlight, actually. You need to distinguish OCD from other disorders that can present with somewhat similar symptoms. The material lists conditions like generalized anxiety disorder, hoarding disorder, body dysmorphic disorder, BDD, and specific phobias.
So quite a few possibilities.
Exactly. And to do this properly, the notes emphasize the need for a comprehensive psychiatric evaluation. This means a thorough look at the symptoms themselves, assessing their impact on the person's daily life, and importantly, considering any coexisting psychiatric conditions they might have.
Okay, pulling back for the big picture.
Yeah.
How common is this condition? What does the material say about the epidemiology?
The notes provide prevalence data. In the UK, OCD is estimated to affect somewhere around 1% to 3% of the population.
1 to 3%, okay.
For adults, the prevalence is cited as 0.8% to 3%, while in children and adolescents, it ranges from about 0.25% up to 2%. So it's definitely not a rare condition.
Not at all.
An onset typically happens during childhood, adolescence, or early adulthood. Most often, it's late teens and early 20s, but, it can begin at any age. And revisiting that risk factor, the notes mention males often experience an earlier onset compared to females.
Interesting distinction there. Let's really get into what this looks like day to day for someone experiencing it. What does the clinical presentation involve, according to the notes?
Well, the core experience, as we touched on, is having those obsessions, those intrusive thoughts, images, or urges that cause significant anxiety or distress.
Right, the intrusive thoughts.
And then feeling compelled to perform compulsions, the repetitive behaviors or mental acts aimed at reducing that anxiety or preventing some feared outcome. The notes give common examples that paint a clear picture. Obsessions might include intense fears of contamination.
Like germs.
Exactly, germs, dirt, or fears of causing harm to oneself or others, or distressing unwanted taboo thoughts, maybe sexual or religious ones. Compulsions often involve excessive cleaning or washing, repeated checking.
Checking locks,
Yeah.
stoves.
Yes, locks, appliances, things like that. Or counting in specific patterns, maybe rigidly arranging objects. A crucial point the material makes is that patients often know their thoughts and behaviors are excessive or unreasonable, but they feel a lack of control over them. They feel like they have to do them.
That internal conflict must be exhausting.
Absolutely. And the notes then go into the specifics of diagnosis, following standard criteria like from ICD-10 or DSM-5. This requires the obsessions, compulsions, or both causing distress, consuming a significant amount of time, often stated as over an hour a day, or significantly interfering with daily life.
An hour a day, wow.
At least. And it's vital to rule out the effects of substances or other medical conditions, and the symptoms shouldn't be better explained by another disorder. The material defines obsessions clearly as recurrent, persistent, intrusive, and unwanted thoughts, urges, or images. Compulsions are defined as those repetitive activities or mental acts performed to prevent distress or dreaded situations. It also notes that patients can have varying levels of insight into how excessive their symptoms are. Some recognize it, some less so.
And the notes mentioned ICD-11 criteria specifically.
Yes, delving a little deeper, the notes list points from ICD-11. These reiterate that the obsessions or compulsions must be time-consuming, at least that hour per day mark. The material emphasizes their origin within the patient's own mind, their repetitive and unpleasant nature, and that at least one is acknowledged by the patient as excessive. There's usually an attempt to resist them, though this resistance can be minimal in long-standing cases, and importantly, there's no intrinsic pleasure in performing them. It's about reducing distress, not enjoyment.
Right.
Ultimately, these symptoms cause distress and interfere significantly with social or individual functioning, often simply by consuming so much time.
Wow, that level of detail in the criteria really highlights the specific nature of OCD beyond just, worrying a lot or being neat.
Exactly.
It sounds like this condition rarely appears in isolation, though. What does the material say about conditions frequently associated with OCD? Comorbidities.
You're absolutely right. Comorbidities are very common, and the notes list a significant number. These include depression, social and other phobias, alcohol misuse, general anxiety disorder, body dysmorphic disorder, BDD, eating disorders, schizophrenia, bipolar disorder, Tourette syndrome, and autistic spectrum disorder.
That's quite a list.
It is. And seeing this list helps understand the complexity someone with OCD might present with during assessment.
Which brings us to assessment. The notes seem to stress its importance.
Hugely important, because many individuals with OCD don't just volunteer their symptoms, perhaps due to shame, or maybe they just don't recognize them as OCD. So assessment involves actively identifying potential cases, particularly those who might be at higher risk, maybe if they have one of those listed comorbidities.
Makes sense.
It also requires thoroughly evaluating how severe the symptoms are and their impact on every aspect of daily life, school, work, relationships, social activities. Assessing the risk of self-harm or suicide is crucial, as is actively looking for those comorbid conditions like depression. The notes also cover arranging referral to appropriate specialist care based on severity, ensuring continuity of care, especially for young people transitioning to adult services,
Okay.
and helping patients understand the involuntary nature of their symptoms, maybe through patient information or self-help groups. Considering cultural, social, emotional, and mental health needs is essential. And importantly, if the patient is a parent, safeguarding concerns for children must be addressed.
It's clear that assessment is really comprehensive.
Yeah.
But are there any specific medical tests for OCD? Investigations mentioned in the notes.
The notes are very clear on this point. There are no specific diagnostic tests for OCD.
None at all.
No. The diagnosis relies entirely on that comprehensive psychiatric evaluation we just discussed, assessing the type and severity of symptoms, their impact, how long they've been present. The material mentions that standardized interviews, rating scales like questionnaires, can be helpful tools to assist in diagnosis and monitor severity.
Tools, but not definitive tests.
Exactly. They aren't diagnostic on their own. Psychological assessments and medical tests are only used to rule out other potential underlying conditions or to evaluate existing comorbidities. The structured clinical interview for the DSM, or SCID, is mentioned, but the notes clarify this is more commonly used in research settings than routine daily practice.
Okay, so diagnosis is purely clinical based on evaluation. How do the notes say we should help people with OCD? What does the management section cover?
Right, management. It's structured into non-prescribing and prescribing approaches. To objectively measure and track symptom severity, the notes mention a tool called the Yale-Brown Obsessive-Compulsive Scale, or YBOCS.
YBOS?
Yeah. A higher score, like over 24, indicates severe symptoms. The notes state the overall goal of treatment is achieving full recovery or remission, which is considered a good response.
And the non-prescribing route.
As for first-line treatment without medication, the notes emphasize cognitive behavioral therapy, or CBT.
CBT. Yeah.
And specifically within CBT, the most highly effective technique is exposure and response prevention, or ERP.
ERP, how does that work?
Well, it involves working with a therapist to create a hierarchy of the patients, triggers the situations or thoughts that provoke their obsessions and compulsions. Then, the person is gradually exposed to these triggers in a controlled way, while learning to refrain from performing their usual compulsive behaviors or mental acts.
So facing the fear without doing the ritual.
Exactly. It's challenging, definitely, but very effective, according to the notes.
Okay, and the prescribing side? Medications.
On the prescribing side, medications can be used. Sometimes alone for milder cases, but more commonly combined with CBT for moderate to severe OCD. The notes list the first-line medications as clomipramine, which is a specific type of older antidepressant, a TCA.
Tricyclic, right?
Yes, serotonin specific. And selective serotonin reuptake inhibitors, or SSRIs, naming fluoxetine, sertraline, and paroxetine as examples. The material notes that medication doses often need to be increased over several weeks to find the right level, if there's only a partial improvement after about 12 weeks on a med.
So if it's not quite working.
Right. The note suggests considering using two medications together, dual pharmacotherapy, for instance, adding clomipramine to an SSRI. In severe cases, especially if the person has poor insight into their condition, the notes mention that antipsychotic medications like haloperidol, risperidone, or aripiprazole might be considered to augment the main treatment.
Augment meaning add-on.
Add on to boost the effect, yes. And a critical point for preventing relapse, according to the notes, is that treatment should continue for at least a year after symptoms have resolved.
A whole year after getting better.
To reduce that relapse risk.
What about kids? Is management different?
Yes, management is adapted for children, according to the notes. For mild functional impairment, the initial steps are guided self-help and family support. For moderate to severe cases, the notes recommend referral to Specialist Children and Adolescents Mental Health Services, or CMHS.
CMHS, okay.
For psychological therapy that actively involves the family, using CBT and ERP. The notes add an important caution about prescribing SSRIs in children. This absolutely requires involvement and supervision from a specialist child and adolescent psychiatrist. You don't just start that in primary care.
Right. Specialist involvement is key there.
Definitely. Focusing on the use of SSRIs generally, the notes confirm they are commonly used in both adults and children with OCD. It's vital to carefully monitor for potential side effects, particularly noting the risk of worsening anxiety and, importantly, suicidal thoughts, especially early on.
That's a serious consideration.
Very. The material lists several recommended SSRIs for adults, including fluoxetine, fluvoxamine, paroxetine, sertraline, and citalopram. However, for children and young people, the notes specify that only sertraline and fluvoxamine are licensed for this use.
Only those two for under 18s.
According to these notes, yes. And crucially, in this younger age group, SSRIs should only be prescribed in conjunction with CBT.
So never medication alone for kids.
Not according to this guidance, no. Always with psychological therapy.
What if these treatments don't work? The notes mention treatment failures.
Yes, unfortunately, about half of people treated with SSRIs may have an incomplete response. The material lists options for these cases. First, optimizing the dose and duration of the current medication.
Give it more time or a higher dose.
Right. Or trying a different SSRI, considering clomiframine, using those antipsychotics we mentioned for augmentation, or perhaps intensive inpatient therapy for very severe complex cases. In extreme treatment-resistant situations, the notes mention that neurosurgery or transcranial magnetic brain stimulation might be considered, though this requires very careful consideration of the risks and benefits. These are not first-line options by any means.
No, definitely sounds like later-stage considerations. That's a really comprehensive breakdown of the management options covering different scenarios and age groups. So what's the overall outlook for someone with OCD, according to the notes, the prognosis?
Well, the material states that treatment, particularly combining CB-terp and medication, can lead to significant symptom improvement, so there's definitely hope. However, it's important to remember, as the notes point out, that OCD is considered a chronic condition.
Chronic meaning long-term.
Yes, long-term. While remission, where symptoms significantly reduce or disappear, is possible, relapse can occur. The notes stress that early intervention and consistent ongoing management are vital for achieving better long-term outcomes.
So management is often an ongoing process.
It often is, yes.
Finally, what are the potential downsides or difficulties associated with the condition itself if it's not well managed? The complications mentioned.
Yes, the notes list several potential complications. These include significant functional impairments that can severely impact work, education, relationships, and just overall well-being.
Affecting all parts of life.
Pretty much. There's also an increased risk of developing other mental health disorders alongside OCD, such as depression, anxiety, and substance abuse. And the notes highlight the serious risk of suicidal thoughts behaviors, particularly in severe or untreated cases. This again emphasizes why early intervention and ongoing support are crucial for preventing these severe consequences.
That truly was a comprehensive look at obsessive-compulsive disorder, pulling out all those key details from the revision notes you shared with us. It feels like we've covered the definition, causes, presentation, how it's diagnosed, managed, and what the future holds.
It really does highlight how understanding all these different facets, from the neurobiology to the clinical presentation to the specific treatment approaches like ERP, is absolutely essential for getting a solid grasp on this condition. And thinking about the prognosis, if treatment can lead to remission, but relapse is common and it's considered a chronic condition. What does that tell us about the ongoing journey of managing OCD, even when symptoms are controlled? It raises an important question, I think, about the necessity of strong support systems and maybe long-term care strategies to maintain that well-being, beyond just the initial treatment phase.
That's a really potent thought to leave us with. We've taken a deep dive into the world of obsessive-compulsive disorder today, using your revision notes as our guide to unpack all that crucial information.
We sincerely hope this structured breakdown has provided you, the listener, with a clear, high-yield way to process this important material.
Remember, this deep dive was built specifically from the source material you provided to us. If you found this helpful for your revision or just expanding your knowledge, there are more resources available.
That's right. You can find helpful materials related to this topic and others at PassTheMSRA.com and FreeMSRA.com.
PassTheMSRA.com and FreeMSRA.com. Until our next deep dive.